My name is Charalambos Solomides. I'm a professor of pathology, anatomy, and cell biology at Sidney Kimmel Medical College in Philadelphia, and the director of cytology at Thomas Jefferson University Hospital. This is my disclosure. Immunohistochemistry is the use of antibodies in tissue sections to react with antigens to help with diagnostic and research applications. We use immunohistochemistry to identify tumors, to classify tumors, to utilize prognostic markers, predict response to therapy, identify biologic behavior, proliferation, for example, apoptosis or metabolic activity, and identify infections and other diseases. The detection of the antibody-antigen reaction is achieved either by immunofluorescence, the use of fluorescent dye, or by an antibody conjugated to an enzyme that can catalyze a color-producing reaction, like in the case of DAB. Here we have an example of immunofluorescence, and actually a multiplex immunofluorescence. You have 5 different antibodies: CD20, CD3, CD8, CD68, FOXP3, and at the lower right side, you have the combination of the 5 different antibodies. You can see the individual antibodies by using specific filters, or you can see the combination. Immunofluorescence is used for decades. It actually started in the 1940s. Right now is utilized predominantly by researchers. And in the clinical practice, we use immunofluorescence in the cytogenetic lab, specifically for the fish probes, and also for kidney and skin pathology. The advantages is that this is a cheap technology, and also you can use many different colors that are available. The disadvantage is that you use a dark room to review the slides, and also you have to have a specific fluorescent microscope. So this is not available for the average clinical pathologist. The immunohistochemical state at the present is basically, as everybody knows, the brown stain. This is what we use everywhere in pathology. Every pathologist is familiar with this. We use basically different antibodies that they are marking either the membrane, the cytoplasm, or the nucleus, and this is how we identify positivity. In many big places, academic places, for decades now, they are using double stains. These are combinations of 2 different antibodies. And we're utilizing DAB and the red chromogen to identify the 2 different antibodies. We take advantage of the positivity at different parts, different compartments of the cell, or the positivity at 2 different types of cells that are mutually exclusive. This is an example of a TTF1 napsin, TTF1 being the brown nuclear stain, napsin A, the cytoplasmic granular red, and this is for the identification of the lung adenocarcinoma. Here we have another example, P40 CK56 for squamous cell carcinoma, P40 being the brown nuclear stain, and CK56 the cytoplasmic red. This is an example of identifying the myoepithelial layer in lesions of the breast, proliferating breast lesions, trying to make sure that we're dealing with a benign thing and there is no malignancy here. Whenever you see the myoepithelial layer intact, it means you are not dealing with an invasive tumor. P40 and calponing. P40 be the nuclear brown and calponing the cytoplasmic red. Very useful in breast pathology. Another example is trying to identify different types of cells. Myepithelial, positive for nuclear P63, brown stain, and epithelial cells that are positive for CAM5.2, which shows you the red stain. On the left-hand side, you can see the neoplastic process, and on the right-hand side, you can see the benign salivary gland elements with the ducts and the acinar cells. In this case, we are dealing with a benign neoplastic process, pleomorphic adenoma. Another example of a double stain is the CDX2 and CK20, widely used for identification of colonic adenocarcinoma. Again, CDX2, the brown, CK20, the red. Here we have a section from a prostate, and you see the racemase is the cytoplasmic granular red stain that indicates prostatic adenocarcinoma, while the glands that are lined by P63 and high molecular weight keratin, both of them as brown, highlight the benign prostate glands. So this is how you're using this double stain, which is actually a double stain, but 3 antibodies. Metastatic carcinoma in the fluids. We have a double stain here that they use very commonly in our lab, and this is the BERP4 calredinin. BERP4 is an antibody that stains epithelial cells that are not mesothelial. That means if you have an epithelial cell in the fluid that is not a mesothelial cell, by definition is malignant. So, and the calredinin is the red stain that actually shows you the benign mesothelial cells present in your specimen. So, double stain BERP4 calredinin for identification of metastatic carcinoma in cytology fluid. So this is what we are doing right now. And now we're going to talk about possibilities for the future. Recently, several companies have developed new detection kits and more chromogens for making light microscopy chromogenic multiplex a reality. I'm going to talk to you about our experience at Jefferson with chromogenic multiplex. At this time, all these products that are mentioned here and the assays that we are talking about are for research only. And basically what we have done is we develop chromogenic multiplex assays on the Discovery Ultra IHC staining platform using detection kits and chromogens from Roche Tissue Diagnostic. Again, this is for research only, but I think this is something that may have, and I believe they will have some clinical use in the future. So I'm going to show you examples from different assays that we develop. First, the quadruple 4 color immunostains for the classification of non-small cell lung carcinoma. Then I'm going to show you co-expression of antibodies with color colocalization, protein expression together with the dual-ish for HER2. Very nice stain, I think should have some clinical use in the future. B and T cell lymphomas that are EBV driven, this will be like CD2 or CD79A together with the EBER in situ hybridization. And we developed also a triple stain for metastatic carcinoma in cytology fluid by adding a third marker, the CD163 for macrophages. And I'm going to show you some nice pictures about this. So let's start from the quadruple stain for non-small cell lung carcinoma. Here you have 4 serial sections from the same tumor, the same slide, the same actual paraffin block. You have the TTF1 on the top next to napsin showing you an adenocarcinoma component, P40 and CK56 at the bottom, showing you a squamous cell carcinoma component. Now, the fifth slide, we did the quadruple multiplex immunohistochemical stain that basically shows you everything together. Instead of having 4 sections, we have all 4 antibodies on one section. And to make it on a higher magnification, you can actually see nicely TTF1 yellow, napsin A is the purple cytoplasmic granular stain, P40 is the teal or blue nuclear stain for the squamous cell, together with the CK56 as brown stain over here. So this is basically one section, 4 antibodies, you have your diagnosis. Another example, these are pictures from a very recent publication. A few months ago, we published this data in the Annals of Diagnostic Pathology. We ran a series of a cohort of 264 non-small cell carcinomas of the lung, stained them with the quadruple multiplex, and then we tried to come up with a diagnosis. We achieved very nice data, and you see here basically on the left-hand side the adenocarcinomas. You see on the right-hand side the squamous cell carcinomas, and this is an example of a case that had adenosquamous basically together, adenocarcinoma and squamous cell carcinoma, clear-cut and very easily identifiable with 4 markers at the same time. Here we replace the brown with a DAB, and we have basically TTF1 yellow, napsin A purple, teal as P40, and CK56 as the DAB. So basically, in the if you have the individual stains, you have to go back and forth, trying to find the region that you are questioning whether there is another component. When you have all 4 together, it's much more easier for you to identify exactly where the mixed tumor is present. So this was a quadruple multiplex for identification of non-small cell lung carcinoma. The next thing we did is we tried to take advantage of the differential stain of CK7 and CK20. Those of you that are actually practicing pathologists, they know that these are 2 markers that we use to try to figure out, in cases of unknown primaries, where tumors may be coming from. On the top, you have CK7 as yellow. Next to it is the CK20 as a purple. And at the bottom, you have a tumor that is positive for both CK7 and CK20, giving you the result of this orange color as co-expression of the yellow and the pink and purple. Now, why is this useful? I mean, for example, some tumors that are CK7 positive, CK20 negative, lung, for example, breast, upper GI. Tumors that are CK7 negative, 20 positive, lower GI. Tumors that are 7 positive, 20 positive, urothelial carcinoma, for example, or upper GI stomach can be positive. And tumors that are negative for 7 and 20 are tumors from liver and, of course, the prostate adenocarcinoma. So by knowing how the differential stain between these 2 markers is, you have a good sense where the tumor of unknown primary may be coming from, and you can add additional markers to nail your primary. This is the co-expression of antibodies with multiple colors. A very nice example of protein expression together with in situ hybridization is the HER2. Right now, we practice that the HER2 expression with protein immunohistochemical stain, we do it first. We score it as 0, 1, 2, and 3. Cases with 0 and 1 are negative. Cases with the score 2 are considered indeterminate, and with score 3 are considered positive. The cases that are scored with +2, we have to reflex it right now to either FISH for HER2 or dual in situ hybridization with HER2. How about if we do this all together? So here you have an example of the teal or the blue is the protein expression of HER2, and you have the HER2 probe in situ hybridization as the silver or black, what you see, and the chromosome 17 is going to be the red dot that you see in the nucleus. So by having this assay protein expression together with dual in situ hybridization, you basically achieve the reflex test together with the original test at the same time. You can save time, and you can actually see exactly where the questionable +2 cells are and identify the amplification of the HER2 if it's present or not present. So protein together with the dual in situ hybridization. Another example of protein expression and in situ hybridization is we can have in lymphomas. Here we have an example of a T-cell lymphoma positive for EBV. The markers are CD2 for the T-cells and EBER in situ hybridization for the EBV. The next example is a B-cell lymphoma driven by EBV. 79A is a B-cell marker, and Iberish is basically the silver nuclear that you see over here, positive for EBV. Fluids, cytology fluids. I showed you before the double stain that you are currently using in the clinical practice, PERP4 with carradining. Here we added, of course, a third color and the third antibody, that is the CD163. This is for a macrophage. You can replace that with 68. It's going to be exactly the same thing. So you have a macrophage marker as yellow in the background. So you see how many macrophages you have in your fluid. You have the teal color indicating the mesothelial cells that are benign in the background. And then you have your purple showing you the clusters of the metastatic carcinoma. Higher magnification, everything is clean and recognizable. Inflammatory cells in the background are just the hematoxyl encounter stain. This particular triple stain is going to be very useful in situations where the tumor content is very low. Look at this field that we have on the slide. There is a single small cluster of tumor cells in the background of all these benign elements, macrophages, mesothelial cells. Sometimes the reactive mesothelial cells can look very ugly, easily make a mistake. By this triple stain, you can very easily recognize where is your tumor. Higher magnification, you can actually see exactly, so making your diagnosis much, much easier. This is the same example of a triple stain in the fluid. Here we're dealing with a tumor that was basically not clustering, but were predominantly individual tumor cells that can very easily be confused with, background macrophages or mesothelial cells, different colors, different antibodies, identifying different classes of cells, giving you very easily the correct diagnosis. And of course, I put these two slides next to each other to show you that you can actually play with colors, switch colors on chromogens on different antibodies, and you can develop your own multiplex depending on what you feel is easier for you. So these were examples of potential usage of multiplex in the future that can be applied and be useful in the clinical practice. Now, for research. Things are becoming more interesting, a little more complicated, more complex. We developed at Jefferson five different antibodies together, 5 different colors. The one as PD-L1, CD8, FOXP3, CD163, and MCT4. You know about the PD-L1, very important for immunotherapy, CD8, the T-cell, FOXP3, basically the Tregs here, CD163, the macrophages, MCT4, this is a metabolic marker that we decided to use in this particular setting for this particular cohort of what we're examining. The next 5-plex that we did was for non-small cell lung carcinoma, and we decided to use just the CD4, CD8, FOXP3, CD20, and A1. Again, these are research products only, and these are examples of our multiplex that were used in different research settings at Jefferson. We're going to talk about the first 5-plex. This was employed in a cohort of head and neck squamous cell carcinoma. To develop this 5-plex, we used tonsillar tissue, sections of tonsils, because tonsils could actually give us a positive control and a negative control for PD-L1. It has a lymphoid tissue in the background that is going to definitely have CD8, FOXP3, CD163, and we were pretty sure that we're going to have cells with metabolic activity. So we actually optimize our 5-plex on tonsillar tissue. This is another example of tonsil, the PD-L1 positive cells in the crypts, and here you have different types of immune cells or lymphoid cells that you have in the tonsillar tissue. All right. We evaluated head and neck tumors. Some of them were PD-L1 positive, some of them were PD-L1 negative. And basically here you have an example of a PD-L1 negative squamous cell carcinoma. In the center of the picture, you have a tumor cluster that is stained only with the hemadoxylin background stain, no other stain at all, surrounded by CD8s, FOXP3, and CD163 cells. The next example is the squamous cell carcinoma that is PD-L1 positive. You have basically the positive tumor cells staining with brown, surrounded here by CD8s and macrophages. You rarely see any FOXP3 positive cell. So what we decided to investigate here was the microenvironment of the tumor. So we had to choose areas that are within the tumor. You see here the population of immune cells that are present within the tumor on the left side of the picture. And then you see basically on the right side tumor as well as the periphery of the tumor. And you see a lot of CD8s and FOXP3 cells at the periphery near the edge of the tumor. This is an example of another specimen from the same cohort. Here you have a very metabolically active squamous cell carcinoma and evident with the positive MCT4 as a pink or purple marker. And again, you see the lymphoid infiltrate surrounding the tumor. So these are good images, nice images. And the question is, how do we analyze this? I mean, what information can you get out of these beautiful images? After we performed the multiplex, we scanned the images as a whole slide image on our scanners, and then we use an image analysis basically from Visiopharm platform. And we developed, together with Visiopharm, Thomas Jefferson University, and Visiopharm, we developed a private app or a private algorithm to analyze the concentration and the interaction of the different cell types in specific regions of interest in relation to the MCT4 and the PD-L1 expression in the tumor and the surrounding stroma. So that was our goal. That was what we decided to examine. Here you have basically our different parameters. Pink or purple is the MCT4 metabolic activity. DAB is a PD-L1 expression. Yellow is macrophage markers, 163, CD163. The teal or blue is the CD8. And the nuclear red is the FOXP3, the regulatory T cells. So, as you can see, there are certain cells that are going to be positive with more than one color. For example, a macrophage can be positive with PD-L1, positive for MCT4, and going to be also positive for CD163. A tumor cell can be positive for PD-L1 and MCT4 at the same time. So we're going to talk about this further down the road. So what we do basically is you have to define your regions of interest. You have to annotate your slide in the Visiopharm platform, apply your algorithm, and you're going to have a classified image after the algorithm is basically run properly. This is an example of a section of squamous cell carcinoma of the head and neck that we annotate, define the tumor area, define the margin. The margin can change. I mean, this is an arbitrary measurement. You can have it at 20 microns, 50 microns, 100 microns. It's up to you what you want to investigate. And then after the algorithm is run, you are going to have a classified image overlay that you are going to have the different cells identified that you are interested. And of course, we set some parameters here, like we wanted to see the interaction between CD8s and FOXP3. So we measure the CD8 cells within 10 micrometers of FOXP3 cells, and also the CD8 cells within 10 micrometers of PD-L1 positive tumor cells. So the goal was, again, to see the interaction of the different immune cells and the interaction of PD-L1 with some of the immune cells. After the app or the algorithm is run, the computer is going to tell you concentrations of cells in specific areas of the tumor, and it's also going to tell you the distances between specific tumor types depending on your question. In this example, it was CD8 for FOXP3, and we have the different concentrations of the different types of cells in the different regions. It looks a little bit easy, but in reality, we have a lot of challenges. Basically, the problem arises because of the high cell density, overlap of cells, staining variability. Sometimes the hemadoxal encounter stain, sometimes we're interfering with the TIL. color colocalization, meaning cells that were positive with more than one colors, creating a problem separating and classifying them. And also macrophages, we figure out that the macrophage is a cell that can take different shapes in the sections. So it was a little bit interesting to classify these cells because of their variation. The result of all these challenges was that we have to spend an enormous amount of time trying to basically make sure that what the algorithm was using and measuring was accurate. We have to do extensive annotations, repeat annotations, reruns of the algorithm, and trying to QA the slide based on the eyeballing and make sure what we are looking at is exactly what we think we are measuring. And with all this in mind, we got in touch with Visiopharm, and Visiopharm were nice enough to let us use their artificial intelligence module. And here we're talking about a complete different world now. By using the artificial intelligence module, things are much, much easier. The initial result that we experience are extremely promising. Of course, you have to train your AI, you have to train with the new algorithm, your questions and everything. But in reality, the result is much faster, much more accurate, requiring less quality control and quality assurance of your results. So this is a superb thing that I think this is a way to go. If we are going to analyze complex pictures, complex images with multi-parameter questions, nowadays AI is the way to go. Of course, you have to consider that this is not a cheap proposal. You have to have powerful hardware, very good graphic cards, and of course there is an initial course in the AI module. So this was our experience with the head and neck cohort that we ran, a research that basically led to several publications. Some of them came already out, some are coming out from Jefferson. So the next 5-plex that we developed is basically a multiplex for non-small cell lung carcinoma. And again, the question was microenvironment of the tumor. Now we set up basically a different set of antibodies, and we just evaluating CD4, CD8, FOXP3, CD20, and A1A3. The analysis of this now is much, much easier because you have a complete separation of everything except the CD4 and FOXP3. So these are basically different populations that they have a single color. CD4s can be positive with FOXP3, but again, here we take advantage of the staining at different compartments of the cell. FOXP3 is a nuclear stain, CD4 is a cytoplasmic stain. So you can actually teach your algorithm exactly what you want to analyze and what you want to measure. The yellow color used for A1A3 was a requirement from our researchers because many of them were not pathologists, and they wanted to make sure that they see exactly where the tumor is when they do their measurements. And again, we have purple as the CD20, teal or blue the CD8, and the FOXP3 is the nuclear red. And you are going to realize that the nuclear red is always positive in the CD4 positive cell, or a subclass of a subgroup of CD4 positive cells that are going to be DAB positive. All right, and while we were playing with this, we realized one very important thing. this is exactly the same 5-plex that I show you with the previous picture, but somehow the A1A3, instead of yellow, is orange. What we used was actually the yellow as well. So the difference between these two multicolor images is the sequence of laying down the colors, which basically tells you that the sequence of laying down your colors on the slide is very important. If you put the yellow as the last color, it's going to remain yellow. If you put the yellow as your first color on the slide, it's going to turn, after applying everything else, into an orange color. The good thing about this, though, is that this is a constant thing. That means there is no sometimes going to be yellow, sometimes going to be orange. It's always an orange color if you put it first. So you can, for purposes of quantifying, it doesn't really matter. So these were examples of research applications for the multiplex with chromogenic immunohistochemistry. The advantages is that you don't require a special microscope. You don't require to be at the dark. This is something that can be evaluated very easily by the practicing pathologist. So even for research purposes, this could be a very nice collaboration between researchers and practicing pathologists. Also now, if you think about it, by looking at the slide, just by looking at it, if you have a multicolor, multiplex immunohistochemical slide, you are getting so much more information just by looking at a single slide. So, and it's very helpful in the diagnosis of postcellular specimens in cytology. It's going to be an extremely important thing in tumor diagnosis, especially nowadays that the tumor diagnosis is happening with minute specimens. The specimen that the first diagnosis is going to be made usually these days is an FNA or a small core biopsy, and then the oncologist is required so much information, including molecular testing, from these tiny little pieces of tissue, and this is where multiplex can be very useful. With one section, we can give them classification, you can give them so much more information, not requiring many sections, trying to make a diagnosis and basically waste material. So these are some of the advantages that you can have with the multiplex. In the future, the future of pathology, if we think about it, is going to become a digital pathology. So there are many ideas about this, and there is a lot of talk about this. In 10, 15 years from now, or some people actually say less, we're not going to have a microscope. We're going to have digital images coming on our computer, and as pathologists, we have to evaluate them. And here is basically where by adding multiplexing, by adding image analysis, by adding the AI modules, you are going to have a tremendous information coming out of the pathology department in the near future that is going to be so helpful for the oncology and for treatments and everything else. So in other words, right now what we see as pathologists, we see a slide and we're giving a qualitative diagnosis. In the near future, I think we're going to be able to quantitate our diagnosis and give a qualitative and quantitative diagnosis at the same time. Okay, the disadvantages. The major disadvantage here is that this is a new technology and has to be embraced by the practicing pathologists. When I showed these images to colleagues, some of them, they complained that too many colors are too confusing. So, I mean, this is something that basically we have to basically accept. The good thing is that the new generation of pathologists, the young pathologists, are extremely happy with all these possibilities that they're coming down the road. The other issue here, if we are going to use multiplex in the clinical practice, then we have to think about the cost. Some of the kits are expensive, and reimbursement has to be an issue. Basically, this is something that we have to face. Regarding the research components, I mean, you have, in addition to the immunofluorescence, that was basically the only thing that you could do multiplexing. Nowadays, you can also have a chromogenic multiplex. Still at this point, we have a limited amount of colors, 5, 6, 7 colors only. But I'm sure with the image analysis, new technologies, and new methodologies of using how to use the chromogenic and light microscope, things are going to change in the near future. So the most important thing here is you have to have quality control of what you are preparing. The chromogenic multiplex is a complex assay, and really you cannot have it, you know, you really have to pay a lot of attention to your quality control. This is how you are going to keep it, you know, at the forefront. And at this point, I want to thank my collaborators from Thomas Jefferson University, Robert Stapp, helped with the image analysis, and the people that helped me with the technical aspect, Raymond O'Neill, Dorothy Glaze, Jennifer Gregory, and of course, our collaborators from Roche Tissue Diagnostic, my friend Esteban Roberts, Wendy French, Larry Morrison, and Lauren Behrman. And at this point, we are done. Thank you very much for your attention.